This is the second in a series of conversations hosted by the Program on Forced Migration and Health at Columbia University's Mailman School of Public Health. My name is Sara Casey. I'm the director of the Reproductive Health Access, Information and Services and Emergencies, or RAISE initiative, and faculty in the program. And I'm here today with Dr. Therese McGinn, the founding director of RAISE.
Hello, so I'm Therese McGinn. As Sara said, I came to PFMH in 1983 to work in the department's Family Planning Operations Research Program in Africa. Family planning was new. I worked with MOH, Ministry of Health colleagues in about 15 countries to figure out how to introduce these new services and crucially, how to measure change. I went on to work in PFMH's maternal mortality program and humanitarian program, and also taught our wonderful students in the MPH program. My focus throughout my work in PFMH has been data, strengthening data collection and analysis systems and skills to improve the scope and quality of sexual and reproductive health services globally, so that men and women around the world could make their own choices about their sexual and reproductive lives and rights.
And I started working with Teresa when I was doing my MPH in the program, and then came back to work when she started RAISE in there. So sexual and reproductive health in humanitarian settings, which is the focus of our conversation today, has long been one of our program's strengths, something we can see sort of in the prevalence of our alum in the sexual and reproductive health teams at many humanitarian NGOs and UN agencies. The field of sexual and reproductive health in humanitarian settings is relatively new, dating from the mid-1990s. So Teresa, you were already here in the department working on sexual reproductive health, as you said, in development settings, but then you shifted more to work on this issue in humanitarian settings. Could you paint a picture of those early days in the field of sexual and reproductive health in humanitarian settings in your role?
So when I think about how I got started in humanitarian work, I sort of sidestepped my way into it. I had been working in Rwanda for actually many years and was working there on a family planning program in the early 1990s with CARE. It had been conceived as a development program. We were in a rural area in the northeast of the country, and people lived at home in their very rural homes. Then the conflict started and the people moved. They moved south to safer areas, and suddenly the same people we had been working with became internally displaced. So the notion, which as I learned was prevalent in the humanitarian world at that time, that family planning and other sexual and reproductive health services weren't relevant to refugees and displaced, it never made sense to me. It was very clear to me that it was the same people with the same needs and desires around family planning services, and that they still wanted those services when they suddenly became displaced people. So that sort of started me in kind of, again, a sidestep into the linked but different world of humanitarian work. Now we're talking about we're getting into the mid-1990s, and there was a lot going on in the world. It was a very heady time. There were the International Conference on Population and Development in Cairo, highlighted refugees, the International Women's Conference in Beijing in 1995. And for those of you who might remember, Rwanda and ex-Yugoslavia, the wars in those countries were on the front pages of every newspaper in the world for months in 1994. It was very much in the public and political consciousness, not just of humanitarian organizations. They were important political and humanitarian events, because there was such momentum going on that we knew we had to do something. And there was a lot of talk, a lot of meetings, a lot of guidelines, policies, and critically the field manual, the interagency working group's field manual about how to deliver reproductive health services in conflict was developed very quickly. In basically 5 or so years, a lot happened in the areas of policy, guidelines, manuals.
So we accomplished a lot in terms of, as you said, developing guidance and manuals, but how did you help move those gains into sort of field programs and sort of the service delivery?
It was sort of dawned on us that all of this talking was up here and it was not translating to the field. That wasn't happening enough, and understandably to some degree, but we were impatient and we certainly wanted services to reach the people we were trying to reach on the ground in conflict zones. There was a lot of discussions going on, very collaborative. And I think that's key to all of anything that we or anyone had accomplished. The we in here were quite a broad coalition, lots of UN agencies, the International Humanitarian Organizations, some local organizations, development partners as well, and universities. And I think it's fair to say that we at Columbia were in the forefront of the university world, particularly of ensuring that research and monitoring and evaluation were part of the field and headquarters efforts, of all of these efforts at every stage of the discussion. So with our consortium partners, we developed the monitoring and evaluation program. We developed 10 field sites in conflict zones in all regions of the world with comprehensive sexual and reproductive health services, good data collection, and a major focus on communicating and learning and developing skills with each other, sort of among this group of people that worked together for 4 years, really. I think the lessons we took from this was that, yes, we could deliver reproductive health services in these very tough places, that people wanted reproductive health services in their displaced and refugee lives, and that we could do monitoring and evaluation and even research. We could measure change in these areas. So we also confirmed that there were very highly skilled health professionals already working in these places. And so we made it a focus of our program to make sure to involve them with updated training, with supplies, and with ongoing support. They could provide high quality reproductive health services to the women and men who wanted them in these conflict areas.
Yeah, that's when I worked with you as a student on that program. Yeah, so those were sort of heady days where we seemed to get a lot done. You know, the Interagency Working Group on Reproductive Health and Crisis conducted a global evaluation of the state of the field of sexual and reproductive health in humanitarian settings, which we were involved in. And the evaluation ended up showing that far less kind of good quality, comprehensive sexual and reproductive health service delivery was happening in the field than we had hoped. Yeah, how did you respond to these findings?
Yeah, the global evaluation in 2004 was a real wake-up call. Working from the results of the 2004 evaluation, we envisioned a very ambitious plan to fundamentally change the way sexual and reproductive health was addressed in humanitarian settings. To do this, it would require institutional commitment within humanitarian agencies. And for these organizations to make that commitment, they would require solid evidence, solid data from the field, because they are very evidence driven. They're going to only take what has been proven in the field. And so we had to prove that this really was going to work on large scale in multiple settings. For these organizations to make this commitment, they would also require a policy and funding environment in the world that would support these expanded priorities. And we strongly felt it really needed to be done in a very collaborative way to kind of pushing this agenda. So that's how RAISE was born. A generous private foundation funded us to accomplish these exact goals. Columbia, so we at PopFam and Marie Stopes International, which is now MSI Reproductive Choices, led this program with a consortium and local partners in all regions of the world. It remains the largest program in the field, and hundreds of thousands of refugees and displaced receiving services, hundreds of staff of the humanitarian agencies, but also local ministries of health receiving all kinds of training and skills in both clinical care and data skills, which again, we believe are really critical to advance this field. Many of those staff have gone on to leadership roles, again, in Ministry of Health in their own countries, but also in agencies around the globe. And they're really experienced, they're excellent. And I think the work that Ray sort of laid the groundwork to do has also resulted in very strong institutional commitment, which was again our goal from the outset, to sexual and reproductive health in crisis within the partner agencies. These agencies are leaders. They are the ones that are leading the service delivery field in humanitarian crises to deliver these kind of services. It's wonderful to see. I mean, the program, and I think their experience over all of these years did convince them internally that they needed to include reproductive health as business as usual in the work they do on the ground. But again, the professionalism of these agencies, the collaboration, the support that everyone gave each other kind of got us through and made the work count.
And I would say also showing that we could deliver like good quality contraceptive services, including long-acting methods, post-abortion care, in places as different as, you know, Yemen, Somalia, Congo, Chad, Pakistan, Myanmar. And in all of these places, seeing utilization increase, you know, certainly improved the lives of those people, but also really demonstrated to the organizations that they could do this work and they could provide these services. You know, I think these partners together really promoted and pushed for the introduction of a new objective in the MISP, the Minimum Initial Services Package for SRH, to prevent unintended pregnancies. So to ensure that pregnancy prevention would be considered a minimum standard of care in an emergency. And I'm not sure that would have happened without all of this work we did.
And we really shouldn't minimize any of that, because these agencies are not reproductive health agencies. They are humanitarian health and sometimes they deliver other kinds of services as well, but broad health. And as we've known, I mean, from its start in the 50s and 60s, family planning, reproductive health was often enough a lightning rod. We're seeing it again in the world right now. And it can be worrisome for organizations to take that on because they fear, the initial fears were that it risks your other services, which are life-saving and crucial. We're still not there. No. We're still so not there. And I hope we're not moving backwards. You know, there's that concern. But we've certainly moved way ahead in the 30 years that we've been sort of trying to get something done in the field of sexual and reproductive health in crisis.
Yeah, and I think Columbia's convening role, you know, really bringing the partners together and encouraging and facilitating that cross-partner learning and working together might have also given some impetus to and support for them to keep pushing their own organizations.
It would not have been the same again if everyone was doing sort of their own thing. I think having we had a common database, common measurement tools and instruments and indicators, and that again, it just helped it wasn't for comparison, it was for collaboration. It was to see what was working. You know, every field site was different. I mean, there was no cookie cutter here. Every field site certainly had to be different in how services were delivered, and certainly the education piece. But there were a lot of attitudinal shifts that had to happen. Again, that full breadth of what needed to be done to change institutions, to change how these institutions addressed reproductive health in crisis.
And as you say, with having our role, since we're not an implementing partner, we could help them focus on some of those areas that also receive a little bit less support, but are critical for quality of care. You know, supportive supervision.
Yes.
The attitudinal piece, how to address bias. You know, the values clarification, adapting the tools developed by IPAS. And then the data utilization piece, you know, making sure that it wasn't just feeding up data to our common database, but also working with, you know, health workers and program managers on the ground.
Yeah. When we would go, you know, you'd go for a field visit and you'd see the graphs on the wall and the staff there, you know, the midwives, the nurses, usually midwives and nurses, not too many physicians, explaining to you what they'd accomplished and being proud of it and understanding what it meant and figuring out, oh, you know, this happened in May as compared to January. What's happening? How do we shift? How do we so yes, using the data, not just collecting it and passing it up. And the other part, of course, is, I feel like we so often hit the ground running when we got to places because it was our students there running things, So that was always such a treat, to run into graduates, well, in airports, in wherever, in organizations, in the field. And it happens sort of all the time. I mean, that was, our grads are really leaders in this field. We in PopFam had always prided ourselves on very, very clearly merging our research work, our service work, and our academic work. And so we, having students involved in New York, but also on the ground during their practica and all of that. And then again, running into them in the field was always quite a treat.
Yeah. It's like, and also bringing things that we did in workshops in the field into the classroom and vice versa.
Yes, absolutely, both directions.
I run into graduates around all the world, but I also run into former local staff of these organizations worked with from the field. And it's like, wait a minute, you were in that country and now you're here. And
yep. Yeah. And so a question to you, Dr. Casey, is now the present director of the RAISE initiative. Where is the field going now? Where should the field be going? What would the new vision for Columbia be? And what would Columbia's role in the future of SRH in crisis be, would you say?
When we started RAISE, we worked primarily with international NGOs, which made sense because we wanted to, work at a few places and have that affect what they were doing in many places. But I think now, with the much more of a shift towards localization of aid, it's really important to, work, partner, and engage with, women-led organizations, youth-led organizations, refugee-led organizations, kind of local organizations, and work with them to ensure that they can deliver these services, that they can support these services. And, so it's like, now we need a raise for local organizations. After so many years of supporting the international organizations, because we worked ourselves out of a job. These are the people that are leading this world. And it would be really, I think our next phase is really trying to provide more of that support to help elevate and amplify the voices of these local organizations that are already there on the ground, that are already doing some of this work, and helping them to be able to do it better and to be able to have a stronger voice in humanitarian response.
And what would Columbia's role, or PopFam, forced migration's role, be in that? I mean, why not just fund those organizations directly and leave them be?
I mean, we could have said the same thing about international organizations, right? And the donor goes straight to them. I mean, they already were big in getting funding. I think many of these organizations need support to help learn, help be able to participate in, the health cluster, in some of this, these coordination mechanisms, need some of the technical skills that we worked on with these other organizations.
And the data skills, presumably.
The M&E in particular. Yeah, we've been doing a little bit of work with some local organizations, and that has always been sort of one of their biggest requests is for, support on how to make sure they can monitor what they're doing, how can they measure it, so that then they can demonstrate to donors, to funders, that they, have accomplished things which would make them more attractive to funders, and also just helping them to kind of strengthen their technical support, their administrative support, so that they can go for respond to calls for proposals with donors, which is something that many of them struggle to compete against the larger humanitarian organizations.
That sounds like, actually, that would be a wonderful next phase for PopFam, for forced migration and health, and for RAISE, because yes, if the goal is to work ourselves out of a job, then, it needs to be passed on to the organizations that are actually closest to the ground, have perhaps the best perspective on what needs are and how best to serve them. So that would be quite wonderful. I wish you well in doing it.
Thank you. So I just wanted to thank you for joining me today. It's been fun to reminisce and think about.
Yeah, it is, boy.
Hopefully we will see many of our alum at
Yes.
the 25th anniversary. And
That will be an absolute pleasure. Yeah, it is a pleasure to be here today as well. Thank you for the invitation.
thank you.